everybody. Welcome to Pediatric BLS cardiac arrest. My name is Rob Adamski. I am going to be your instructor for this evening. And without further ado, we're going to go ahead and get started. We have two main lesson objectives for today. First is we're going to describe the current techniques for both 1 and 2 rescuer CPR for our pediatric patients, for both infants and children. Number 2, we're going to demonstrate the current techniques of 1 and 2 rescuer CPR for infants and children. All right. Now, what actually is CPR? So, what is cardiopulmonary resuscitation? Essentially, CPR is a medical procedure that combines two techniques. It combines artificial ventilations with a pocket mask, with a ambu bag or BVM, or even mouth-to-mouth resuscitation in an emergency as a last, ditch effort, okay, if you don't have any other options available to you, and then combines that with chest compressions to treat to treat cardiac arrest. All right. That's what CPR is. So it's a medical procedure that utilizes both ventilations, artificial ventilations, and chest compressions to treat cardiac arrest. Now, what is cardiac arrest? Cardiac arrest is a life-threatening medical condition that occurs when a patient's heart stops suddenly and stops perfusing the vital organs. So therefore, there is no blood flow and no importation of nutrients like oxygen and no removal of metabolic waste products like carbon dioxide, lactic acid to the vital organs like the heart, the brain, the kidneys, etc. That is what cardiac arrest is. And realize that cardiac arrest, all right, is where patients are clinically dead. All right. They are apneic, which means they are not breathing and they do not have a pulse. That's what cardiac arrest is. And cardiac arrest usually occurs because of a lethal dysrhythmia or a lethal abnormal heart rhythm, okay, otherwise known as an arrhythmia, that prevents the heart from pumping effectively and therefore perfusing or providing effective blood flow and nutrients and then removal of waste products to those vital organs. That's what cardiac arrest is. So realize that don't let anybody tell you CPR doesn't work. It does. You just need to be realistic as to what CPR will and will not do. Traditionally, and in most circumstances, not all, there are exceptions, CPR alone by itself will generally not restart the heart. All right. It will not save that patient. However, what it does do is provide effective perfusion to the vital organs like the heart, the brain, the kidneys, etc., until more advanced resuscitative measures arrive that will be able to go ahead and restart the heart. CPR keeps those vital organs like your heart, brain, and kidneys alive long enough for those advanced techniques like pediatric advanced life support, like defibrillation, all right, to arrive to get to that patient who's in cardiac arrest. And then that is what actually is going to restart the heart and save the patient, all right? But the problem is, in most circumstances, unless you live right next door to the fire station, the rescue squad, the ambulance agency, or the police department, by the time first responders get to you, that patient may be biologically dead. Okay. And that is where the patient has suffered severe, irreversible brain damage. And those patients we cannot resuscitate. So CPR prevents or minimizes the chances of that happening. And the reason why CPR is so important, and we're going to go into more detail on this, is that once that patient goes into cardiac arrest, they are considered clinically dead. We are under a severe critical time hack or a time crunch. The circumstances vary depending on the patient, their medical condition, the exact circumstances of that emergency. However, in it's been documented, statistically shown that some patients can have as few as 4 to 6 minutes to survive before they suffer that severe irreversible brain damage. So we're under a severe time hack there. And that's where CPR can provide that vital role in slowing down or stopping that clock to give us enough time to show up with the defibrillator, with the advanced life support, the paramedics, etc., to actually restart the heart. Okay. And remember, the ultimate goal for CPR, the ultimate goal for cardiopulmonary resuscitation is to restart that heart. That's what we're trying to do. Because once we restart the heart, we regain that normal heart rhythm that will sustain life, that's going to provide effective perfusion to our vital organs, your heart, brain, kidneys, etc. All right. That gives us the opportunity to have what we call ROSC, all right, or the holy grail of resuscitation. ROSC, ROSC, stands for return of spontaneous circulation. That's what we're trying to achieve. Because if we achieve that in the pre-hospital care setting, that's going to give that patient the best chance at surviving that cardiac arrest incident, that life-threatening medical emergency, and then potentially being discharged from the hospital and then going on to live a normal life. Okay? That's our goal. And it's really cool. So, before I go into the details of why CPR is so important, realize that there's some really cool history behind CPR. So, the historical origins of CPR are fascinating. CPR was created by a team of doctors at Johns Hopkins University and Johns Hopkins Medical School in 1933. That was before World War II. And then another important time point in CPR, in the evolution of CPR and the evolution of resuscitation, all right, is the first resuscitative mannequin, or the first training aid, was developed in 1960 by a team of doctors who in Europe who worked with a Norwegian toy manufacturer by the name of Mr. Laerdal. All right. And nowadays that name's very famous. All right. Laerdal, all right, is a multi-million dollar medical equipment corporation that creates training mannequins and other training aids for ACLS and for resuscitation. So you can see that, since 1933, CPR has evolved, it's been improved, and it's been shown to be the most single important factor that, if done properly, quickly, and effectively, is the number one indicator as to whether a patient who undergoes cardiac arrest will survive or not. That's why CPR is so important. And if you look at those two bullet points there on this slide, yes, CPR, like I said previously, CPR by in and of itself, with a few exceptions, generally won't restart the heart. All right. But what it does do is it keeps the heart and the brain and other vital organs alive long enough for those advanced resuscitative measures, like pediatric advanced life support in our case, all right, like paramedics, like a defibrillator to arrive, and then those advanced resuscitative techniques, equipment, personnel, etc., will convert that lethal heart rhythm that's not effective, it's not pumping blood, all right, it's not perfusing our vital organs, back into one that actually will sustain life. And at the end of the day, CPR prevents or minimizes the chances of that patient who you are working on, who is clinically dead, i.e., pulseless and apneic, that means they don't have a pulse and they're not breathing, from suffering permanent irreversible brain damage and becoming biologically dead, where we can't save them anymore. That is why CPR is so important. And that is why you guys need to pay attention for the next couple minutes. And that's why your CPR classes are so important. Because if you guys take this to heart and you learn how to do CPR effectively and you train and become proficient at CPR, you can actually save a life. Like, I'm not making that up. You can actually save a life. And that's why it matters. And that's why important. That's why it's important. And that's why you need to pay attention. Now, realize that we are under a significant time hack here. So, it's been shown statistically through research that irreversible brain damage can occur in as quickly as 4 to 6 minutes. Sometimes it can take up to 10 minutes, but it's been shown to occur in as quickly as 4 to 6 minutes. That's not a lot of time. And realize that every minute that goes by without EMS, other first responders, the lay bystander, just Joe Snuffy on the street, the Good Samaritan, all right, without any of those people starting CPR or starting other resuscitative measures, all right, every minute that goes by decreases that patient's chance of survival by 10%. Every minute, every 60 seconds. That is why CPR is critical. Now, we're going to discuss the pediatric chain of survival. It's a 5-step process that has been shown, if done correctly, quickly, and efficiently, consistently, this is the best way to guarantee that we give that patient, that infant or that child, the best chance at regaining ROSC, return of spontaneous circulation, and surviving this life-threatening emergency known as cardiac arrest. So if we implement all 5 of these procedures, that's going to give that infant or that child the best chance at survival. So the first one, the first chain or link in that chain of survival is prevention. Obviously, if we can prevent pediatric patients from going into cardiac arrest, that's going to be better for everybody. All right. We're going to have, vastly improved outcomes if we can prevent those children from going into cardiac arrest in the first place. And the reason why is nationally, the statistics indicate that we only get ROSC or save, get that return of spontaneous circulation in just over 11% of our pediatric patients that go into cardiac arrest. So only about 11.4% of pediatric patients nationally do we actually get ROSC on or save. And that's why prevention is so important. So let me give you some examples of prevention for infants and children, prevent them from going into cardiac arrest. We know that the vast majority, almost 76% of pediatric patients that were documented in one study that studied pediatric cardiac arrest, all right, were found that the etiology or the underlying cause of that patient going into cardiac arrest was found to be some sort of respiratory failure. So there was a respiratory emergency that was undiagnosed, unrecognized, or not treated aggressively enough. And therefore, the patient succumbed to that. And then eventually their condition worsened and they went into cardiac arrest. So if we know that 75.8% or just under 76% of our pediatric patients go into cardiac arrest secondary to some sort of respiratory failure, then obviously if we can prevent those cases of respiratory failure, those patients will do much better. So for instance, we have those pediatric patients that drown. All right. So if we can implement safety measures in pools, prevent kids from accidentally gaining access to pools where they fall in and drown, or we can improve the number of kids that are, able to be taught how to swim effectively. All right. So if something bad does happen, they're able to self rescue themselves, or at least, stay afloat long enough for somebody else to come rescue them. So if we can implement procedures like that, like safety measures, like fences and gates, locked gates, and pool covers, and other safety, and have safety gear at the site of the pool, then, or the other body of water, then we can prevent children from drowning. Or if we have pediatric patients that suffer from the medical condition known as asthma, if we can, get those patients good primary medical care and prevent exacerbation or emergency incidents involving their asthma, they're going to do much better. If we can make sure we, provide them good quality medical, primary medical care, make sure they have a good pediatric clinician, make sure they are, diagnosed properly, make sure they get access to, both short-term and long-term medications that will control their illness and or be able to treat any emergencies that arise, we can prevent those patients from having an emergency incident where they do go into respiratory failure and then eventually cardiac arrest. So those are just two examples. That's why prevention in the pediatric chain of survival is so important. Link two is early CPR. All right. Like I said previously, you have no more than 10 minutes, and you may have as little as 4 to 6 minutes to initiate CPR and other resuscitative measures, okay, to provide effective perfusion and prevent that clinical death from progressing to biological death and severe irreversible brain damage, where we're not going to be able to bring those patients back. Okay. So that's why CPR step two, or the second link in that chain of pediatric chain of survival, is so important. And then step three is prompt access to the emergency response system. All right. If we need that pediatric advanced life support or the defibrillator to show up to restart the heart, the sooner we activate EMS, the sooner we activate the emergency response system via 911, usually here in the United States, the quicker we can get those advanced resources that will make the difference, will restart the heart. The quicker we get them there, the better. And that's why it's so important for members of the public, the Good Samaritans, the bystanders, to be trained in first aid and CPR. That way they can recognize life-threatening emergencies, initiate first aid measures to stabilize these patients, and call 911 in a prompt and timely manner so first responders can show up and actually save the patient. And then we talked about the importance of the fourth link in the pediatric chain of survival, or rapid PALS, or rapid pediatric advanced life support, paramedics with advanced airway techniques, with advanced medications, and most importantly, with the defibrillator. Okay. We need them there quickly. We need them there in a prompt and timely manner, hopefully in less than 10 minutes. That's why, because we know those advanced techniques, especially the defibrillator, are what can restart the heart. All right, terminate that lethal heart rhythm, and then allow the heart's normal pacemaker to kick back in and regain ROSC, regain that return of spontaneous circulation, and then save the patient. That's why that's important. And then the fifth and final step is what we call integrated post-cardiac arrest care. That's all those things hospital personnel do both while the patient is in cardiac arrest and or after we regain ROSC to help give that patient the best chance of being successfully discharged from the hospital and then returning to a normal life. Some examples of that would be good quality intensive care medicine, where we institute, tried and tested advanced cardiac life support policies that have been shown to help save lives, and or all the supportive care that hospitals can provide, okay, to help preserve brain function, minimize damage to the heart, preserve the other vital organs, prevent organ failure, okay, all those other things, and then help the patient recover, provide cardiac rehabilitation services to make sure that patients in the best physical and mental condition so that when they are discharged they have the best chance at both survival and returning to a normal, productive quality of life that they had before this emergency. All of that is involved with that integrated post cardiac arrest care. And notice the highlighted link there. The first three links are all basic life support, BLS, what you guys as EMTs do. All right. We as first responders, as EMTs, can help prevent CPR. We can provide early CPR for our patients and also do outreach to the community, train the community members in CPR, train members of the public in CPR, you know, train them in first aid so they know how to recognize emergencies, activate the 911 emergency system, and also provide CPR. And then finally, we can make sure that, we provide that prompt access to the emergency response system. If you get on scene as a BLS unit, as an EMT, and you realize that you're dealing with a life-threatening emergency that may imminently progress into a cardiac arrest situation, you can recognize that situation, contact your dispatch center in a timely and effective manner, request ALS, and then provide good quality BLS care until the ALS personnel show up. All right. So you as EMTs matter. You guys make a difference. Now, these are some very important points to remember and keep in mind when you guys are not only training in class to do CPR, but also when you guys are out in the field working as first responders, as EMTs. These are the points that if you do all these things, you're going to provide the best quality CPR. All of this is best practice. This will teach you the most effective way to perform CPR. So we need to perform CPR at the proper rate, which is 100 to 120 compressions per minute. Just like you heard in the Office video, the Office episode, all right? I don't care what, mnemonic, what way you remember it, all right? Whether you're singing, Staying Alive to yourself, okay? Or you actually have a metronome, all right? Some AEDs and some other defibrillators have little beeping noises, a metronome that you can keep count with, all right? I don't care what you use, but you need to get the proper rate for your chest compressions. And that's because if you do your chest compressions too quickly, too fast, realize that they're not going to be nearly as effective. And that's because if you go over 120 compressions a minute, you're not allowing the heart enough time to refill, all right, with blood. And if you do that and you're doing your compressions at like 150, 200 compressions per minute, you're going way too fast and you're not giving that heart that time it needs to refill with blood, which in medical terms eventually is going to result in what we call decreased preload. Okay. And then if you have decreased preload because the heart wasn't able to fill with blood, every time it pumps, it's not going to pump that much blood out. It's not going to be as effective. All right. And therefore, you're going to have decreased cardiac output. If you have decreased cardiac output, then you're also going to have poor perfusion to the vital organs, heart, brain, kidneys, etc., which is the exact opposite of what you're trying to achieve. So doing your chest compressions, performing your chest compressions at that rate of 100 to 120 a minute is critical. The second bullet point there, we don't want to stop CPR for more than 10 seconds if possible. That also is really important. There is a ton of research out there. It's pretty rock solid that shows that two things. One, if you stop CPR for more than 10 seconds repeatedly, you generally are not going to have a good patient outcome. You're not going to get ROSC. And or if you do get ROSC, they might have suffered permanent irreversible brain damage and or damage to their vital organs like their kidneys, their liver, etc. In addition to that, realize that we as first responders should be doing our best to go ahead and implement a goal of 80% chest compression fraction or 80% CCF. What do I mean by that? What am I talking about when I say what our goal is an 80% chest compression fraction? What that means is 80% of the time you should be doing chest compressions on a scene when you're performing BLS resuscitative measures, when you're doing CPR. So 80% of your time, from the time you get on scene and you start CPR, 80% of that should actually be doing effective chest compressions. That 80% CCF or chest compression fraction will give you the best chance of the best percentage of actually being able to get ROSC, get that return of spontaneous circulation with a good neurologic outcome, where the patient gets to the hospital, they're able to be saved, all right, and eventually they're discharged from the hospital and they go on to live a normal life, all right? So the take home message is once you start CPR, you want to minimize your interruptions, all right? And 80% of your time should be spent thumping on that chest, people. That's the take home message. All right. Then we also found out that, okay, if you want to be in fantastic aerobic shape, you want to be in really good cardiovascular shape, you want to be physically fit, all right, do CPR for 20 minutes 3 times a week, and you will be in great shape. That's how physically demanding CPR is, all right? I have wiped out whole police shifts, all right, as a paramedic doing CPR, all right? That's how physically taxing and physically demanding it is. And so when they researched this, what they found out was even though, you get your diehard, hardcore people that say, I can go forever, right? You know, I'm tough, okay? I can do CPR for an hour, 60 minutes, no big deal. What we really found was after about 2 minutes, even if you're doing CPR, the quality of that CPR decreases dramatically. All right. So, yes, you may still be doing chest compressions, but after about 2 minutes, they're not nearly as effective. That's why we need to switch out our first responders, our personnel who are doing those chest compressions every 2 minutes. We used to set a timer. I've been on codes where we'll set a 2 minute timer, and every time that 2 minute timer beeps, we switch out our EMTs, our firefighters, our law enforcement personnel, our good Samaritans, whoever's doing CPR, they rotate out every 2 minutes. 2 minutes, people. That's all you got. All right. And then, all right, our fifth bullet point there is also critical. As soon as that automatic external defibrillator or that manual defibrillator becomes available, you need to use it. Don't wait. Don't pass go. Don't collect $200. Don't wander around. Okay. Don't do anything else. As soon as that defibrillator shows up, all right, and you can use it, use it. The sooner you administer that defibrillatory shock to the heart, the better chances you have of getting ROSC or return of spontaneous circulation. So once you have it, use it. And then the final bullet point, which is also critically important, is remember that most out-of-hospital cardiac arrests that occur to pediatric patients, infants and children, and remember, we're talking about infants are from birth to 1 year old, and then our children are from about 1 year old to puberty, all right, which may or may not be, 12-ish or so years old. But realize that uh, in most of our out of hospital cardiac arrest patients who are pediatric patients, infants or children, the underlying problem that caused them to go into cardiac arrest, like I said previously, was a respiratory problem that we missed. We didn't know was occurring, or we didn't take it seriously enough, and or we did not treat it aggressively enough, and therefore the patient decompensated, they got worse, and then eventually they went into cardiac arrest. Good examples of that are pediatric patients that end up choking on a foreign body, okay, or they drown, or they have a unrecognized medical condition like asthma, right? So, therefore, the take home message for that last final bullet point is when we have our pediatric patients that have respiratory problems, you need to have a high index of suspicion that something bad may happen, and you need to treat those patients aggressively and monitor them to make sure they're at least stable or they're improving. All right. Because if you get these respiratory pediatric patients that are unstable and or they are decompensating, then you need to treat them more aggressively and or also call ALS or advanced life support to help you out, to help prevent that patient from going into cardiac arrest. Now, these are the protocols for how to perform BLS CPR in our pediatric patients. And we're going to cover both one person and two person CPR protocols for both infants and children. Okay. And remember, so we have infants are from birth to 1 year old. All right. So the position is for one person infant CPR, 2 fingers below the nipple line, and the compression rate is the same. It doesn't change at all for anybody. It's always the same 100 to 120 compressions a minute. Now, the depth does change. How far you push with your fingers or your hand does change. So with one person infant, you're going to compress 1/3 the anterior posterior diameter of the chest, or about an inch and a half. Okay. So you're going to take, quickly eye up, visualize the size of your infant patient, figure out about 1/3 of their overall diameter of their thorax or their chest. And that's how far your compression, or if your brain can't wrap around that, just estimate 1.5 inches. That's how far you're going to do, that's how deep you're going to do your chest compressions. And remember, our compression ventilation ratio is 30-2. So 30 compressions, 2 breaths, 30 compressions, 2 breaths. That's your compression ventilation ratio. Now, for one person child CPR, and remember, this is for children from 1 year old all the way up to puberty. How do you know somebody's in puberty? You're looking for, development of secondary sexual characteristics. Okay. So we're looking for, underarm hair in the guys, for example. Okay. But you're looking for, we treat children as children up until onset of puberty. All right. All right. So for one person child CPR, again, our compression rate's the same, 100 to 120 compressions a minute. Now, our position where we place our hands changes. You're either going to use one or two hands on the lower half of the sternum. And how do you decide? All right, do I use one hand or two hands? That's going to be based on how big you are, how physically fit you are, and then also the size of the patient. All right. If you have a small child and or you're a big guy or a big gal, then go ahead and use one hand. If you have a larger child and or you're a smaller size first responder, then go ahead and use two hands. All right. Pretty self-explanatory. Fourth point is we're going to figure out the depth of our compression. So for one person child CPR, again, you can do 1/3 the anterior posterior diameter of the chest, or about 2 inches now. It's about 2 inches. And again, the compression ventilation ratio for one person child CPR has not changed. It's still 30:2. So the compression ventilation ratio for both types of one person CPR, infant and child, the compression ventilation ratio is still 30:2. So those were the one person protocols. All right. Remember, let me go back a minute. So remember, the key points are our compression ventilation ratio is always 30:2 for one person's CPR, but notice the depth difference. For infant, it's about 1.5 inches. For children, it's about 2 inches. Those are key differences. Now we're going to cover two-person infant CPR. All right. And again, infant from birth to 1 year old. Now, notice the hand position has changed dramatically for two-person CPR. So now we're using the encircling thumb technique. So you're going to take your hands like this, use your thumbs, all right? And you're going to place them in the center of the chest just below the nipple line. Notice the diagram there and notice the picture. That's critically important. Our compression rate, however, does not change. Still 100 to 120 compressions a minute. And the compression depth is the same as one person infant CPR. So about 1.5 inches, or 1/3 the anterior posterior diameter of the chest. Now, the compression ventilation ratio with two rescuer CPR does change. That has changed now to 15:2. So we're doing 15 compressions and 2 breaths. 15 compressions and 2 breaths. All right. So notice the hand position has changed and the compression ventilation ratio has changed. Now we're going to cover two-person child CPR. And again, child CPR is designed for children 1 year of age all the way up to the onset of puberty. Excuse me. Our compression rate still has not changed, nor will it ever change. 100 to 120 compressions a minute. Our compression position has not changed. We're using one or two hands on the lower half of the sternum, just like one person child CPR. Our compression depth has also not changed. You're going to compress the chest 1/3 of the anterior posterior diameter of the chest, or about 2 inches. Finally, the one difference between one person and two-person child CPR is that the compression ventilation ratio does change. One person child CPR, the compression ventilation ratio was 30:2. The two-person child CPR protocol is for the compression ventilation ratio to be 15:2. So notice that once we switch over to two rescuers, we're doing professional rescuer CPR. The compression ventilation ratio changes to 15:2, 15 compressions and 2 breaths. The rationale for that, like I said previously, is that the underlying etiology or the cause of cardiac arrest in many, if not most, of our pediatric patients is a undiagnosed or undertreated respiratory problem, which then resulted in respiratory failure. And so therefore, when we go to two-person CPR for our pediatric patients, we're emphasizing the respiratory component. And that's why we go from 30 compressions and 2 breaths to 15 compressions and 2 breaths to try to maximize the amount of artificial ventilation that we can provide. All right. To emphasize this again, why is the rate of chest compressions so important? The rate of chest compressions is so critical, so vitally important, because if you screw up your chest compressions, all right, you mess things up, you're going too fast, you're going too slow, you're not going deep enough, all right, you're going too deep, all right. All of those errors, all of those issues are going to create a lot of problems for your patient. And therefore, the chances of you getting the Holy Grail, all right, winning, woo, CPR and actually getting ROSC, getting that return of spontaneous circulation, getting that pulse back, saving your patient are going to dramatically and significantly decrease. That's why doing CPR properly and getting that rate of chest compressions is so important. So, if you do your chest compressions too quickly, too fast, realize that your perfusion or the blood flow to those vital organs, your heart, brain, kidneys, etc., is going to be decreased. And if you decrease the blood flow or the perfusion to your vital organs, then they're not going to get enough oxygen to survive, and or equally important but often forgotten, they're also not going to be able to get rid of or eliminate metabolic waste products that can damage or kill those tissues and those organs as well. So you'll have a buildup of lactic acid, a buildup of carbon dioxide in those cells, which then will damage the cells, damage the tissues, and damage the organs. Okay. So realize that lack of perfusion, because you're doing inadequate or improper chest compressions, is going to decrease the perfusion to the vital organs. That's going to cause problems. But in addition, all right, if you're not doing good chest compressions and you're not keeping those vital organs, the heart, the brain, etc., in a good condition with enough oxygen, the chances of them successfully, responding to that defibrillation and to the advanced life support measures that paramedics bring with them, okay, advanced airway maneuvers, medications, okay, etc. All right, the chances of the heart successfully responding to that are also going to be dramatically decreased. So the heart's not going to respond as well to the defibrillation. It's not going to respond as well to the medications that the paramedics give. So that's why both of those reasons are why chest compressions are the most important element of CPR, and why they actually will give your patient the best chance of survival and you the best chance as an EMT, as a first responder, of regaining ROSC, or that return of spontaneous circulation. So we often run into problems. Okay, you're doing CPR. Okay, you're doing them at the proper rate, 100 to 120 compressions a minute. All right, you're doing them at the proper depth. Okay, let's say for an infant, it's about 1.5 inches. If it's a child, it's about 2 inches. Okay, you think you're doing everything right, but you still hear bad stuff. You still hear crunchy noises. Crunchy noises, generally speaking, when it comes to CPR, are not good. Okay. However, okay, what I'm going to show you here and what I'm going to talk about will help put you in the correct frame of mind and help show you that it's not the end of the world. Okay. You may not be doing anything wrong. Okay. So don't freak out. Don't lose your mind. Okay. It still might be okay. All right. Now, what do I mean by that? So, if we hear crunching noises while we're doing CPR, what's actually happening inside our patient? What's the pathophysiology, or what's going wrong in our patient that we hear crunchy noises? All right. Realize that, traditionally, historically, the EMS myths and legends we hear is that if you're not doing CPR unless you're breaking ribs, okay? No, that's no bueno. Okay. Don't do that. But equally important, okay, if you do hear crunching noises, it's not always you breaking ribs. Realize that statistically speaking, a lot of times when you hear crunching noises and you're doing chest compressions, it's actually just the costochondral cartilage separating. So if you guys look at that diagram there on the slide, you're going to see, in addition to the ribs, all the ribs are connected to the sternum and to the spine and to each other via cartilage. All right. That's a normal anatomic structure for our patients. So realize that a lot of times that crunching noise is just cartilage separating. You're not actually breaking ribs. So, therefore, if you do hear crunching noises, what you as an EMT need to remember is check your position. All right. Make sure you're in the right spot. Make sure you're doing your chest compressions over the part of the thorax that you're supposed to. You're not off to the side. You're not too low. You're not too high. All right. Make sure you're in the right spot. But then if you are in the right spot, keep going. Okay. Don't stop. Don't freak out. Don't lose your mind. That's the key point. That's the takeaway message that I want you to take home with you. Okay. So once you double check yourself and you find you're doing everything right, you're in the right position, and you're doing your chest compressions at the correct depth, don't freak out, don't lose your mind, and just keep going. All right. It's more important that you keep providing effective CPR, effective chest compressions, than it is for you to freak out, lose your mind, stop all the time, um, and worry about what all those crunching noises are. Because remember, what did we say? You need to minimize your interruptions to chest compressions to 10 seconds or less. And 80% of your time on scene, somebody should be doing effective chest compressions. You want that 80% CCF or chest compression fraction. That's going to give you the best chance at getting ROS, people. All right. So, again, the takeaway message is yep, if you hear something crunchy, it may be bad, but it may not be. Double check your position. And if you're in the right spot and you're doing your compressions properly and you're doing them at the correct depth, just keep going. All right. Don't stop. Now, realize that, okay, the research has shown if you do break ribs, all right, about 30% of our patients that receive CPR, remember, CPR is a medical procedure, all right, and a lot of medical procedures are not benign. All right, what I mean by that is bad stuff can happen when you perform CPR, when you perform other medical techniques. CPR is the same. So realize that about 30 patients that undergo CPR as a medical procedure because they're in cardiac arrest, about 30% of them suffer rib fractures. All right. At the end of the day, if you suffer rib fractures, but you're alive, you get ROSC and you're discharged from the hospital and you're a walkie-talkie save and you're a functional member of society, I think that's a pretty fair deal. Okay. You survived. You can heal in 4 to 6 weeks from a rib fracture. All right. It'll hurt a little bit, it'll be annoying, but guess what? You're alive. All right. So there you go. That's my takeaway message as far as what happens if you hear crunchy noises when you're doing chest compressions. Now, AEDs, what are they? Why do we care about them? What do they do? And why are they important? So let's go ahead and discuss this. All right. Realize that, and let me give you a little bit of EMS historical trivia. All right. That will place the defibrillator that you guys are going to hold in your hand in your EMT classes training and what you guys are going to use out in the field as the real working model. All right. It's going to put everything into perspective. So the very first defibrillator was created again by that Johns Hopkins team of physicians that created CPR. They also created the very first defibrillator. It was created in 1957. All right. And it weighed 200 pounds. That's 200. 200 pounds, people. So just be happy that you don't have to be lugging a 1957 defibrillator around in the back of your truck. Okay? So things have improved a lot since 1957. All right. AEDs now are, they're very small, they're lightweight, they're very reliable. Okay. I mean, look at it. Like firefighters and cops can use them. Okay. And if they can use them, anybody can use them. That's my little dig on our wonderful fellow first responders that I love and respect. Okay. All right. So, what are AEDs? Automatic external defibrillators are the type of defibrillator that you, as an EMT, will use at the BLS level. What it is a device that administers, it's a medical device that administers an electrical countershock to a heart that is in cardiac arrest, that is not beating properly. It has a lethal heart rhythm that is not providing a pulse and is not providing effective perfusion to that patient's vital organs, their heart, brain, kidneys, etc., because they're in cardiac arrest now. So what AEDs do is deliver an electric countershock to that heart that's suffering a medical emergency. It stops or terminates that lethal heart rhythm and then allows the heart's normal pacemaker to kick back in again. That's what defibrillators do. Okay. Now, some points to keep in mind with defibrillators are that, again, we want to minimize our interruptions in CPR. So when you're on scene, all right, and remember, I told you, as soon as you get that defibrillator, as soon as it's available, you want to use it. Don't wait. However, you also do not want to stop CPR while you're applying the AED pads, while you're getting it set up. Whoever's doing chest compressions needs to continue. The person, the first responder that's applying the pads and getting the defibrillator set up needs to work around their team member that's performing CPR, that's performing the chest compressions. Okay. Okay, now, in addition to that, realize that pad placement may vary between infants and children. So, historically, typically, and I'm going to show this on a slide that's coming up, all right? Historically, pads, AED pads or defibrillator pads go on the upper right, lower left, upper right, lower left, okay? And that's typically what we do for children. For infants, you can also do that. Upper right, lower left. Realize though, because obviously infants are small, okay? And even if you're using infant pads, AED pads that are designed for infants, they may be too large and they may touch each other if you use the traditional placement method, upper right, lower left. So if those pads are touching each other, that's no bueno. That's not going to work, all right? Because the AED will not work properly. You run the risk of you have a situation where you could have the electricity arc and or burn the patient, harm first responders, and or it just won't work effectively. It won't terminate that lethal heart rhythm. So therefore, make sure you don't let your pads touch. Therefore, if you have small infants, okay, and or the pads are touching, and or you have to use adult pads on pediatric patients, which as a last ditch resort, if you don't have the pediatric pads, you can use adult pads on pediatric patients, all right? Then you're going to do what's called the alternative pad placement, which is anterior posterior. So you put one on the front and then you put one on the back, all right? Front, back. So there we go. Now, that last bullet point is important. Yes, you can use adult pads on pediatric patients if you have no other option. It's not ideal, but it's better than not using the AED at all. Whenever you can use an AED, you want to use it. It's going to give your patient a much better chance at survival and you of regaining ROSC. However, we cannot use pediatric pads on adult patients. Realize that. The vice versa, the reverse, is not true. You cannot use pediatric pads on adult patients. And that's because they simply will not provide enough electricity or the Joule setting to restart that adult's heart. So they're going to be ineffective. All right. Now, how does that defibrillator actually save the patient's life? How does it actually make that difference? Okay. So realize that, again, to emphasize the point, defibrillators terminate the lethal rhythm. They stop that abnormal heart rhythm, that dysrhythmia or that arrhythmia that is causing that patient to be in cardiac arrest, to be pulseless and apneic, i.e., not breathing, not have a pulse. All right. It stops that bad rhythm and allows the heart's normal pacemaker to kick back in again, which will then result in a good rhythm. Okay. So this slide illustrates that pretty well. So one of the most common abnormal heart rhythms or lethal heart rhythms, which can be defibrillated, because realize not all lethal heart rhythms can be defibrillated. There's bad lethal heart rhythms that will kill you that a defibrillator won't work on. All right. But that's a little bit above and beyond the BLS scope of practice and skill level. What you guys need to know is that, one of the most common lethal rhythms is VFib or ventricular fibrillation. All right. And the other one that defibrillators can work on, the other lethal heart rhythm, is pulseless ventricular tachycardia. All right. Pulseless ventricular tachycardia or VTAC. Both of those are two lethal heart rhythms that a defibrillator can counter shock, terminate, and stop, and allow the heart's normal pacemaker to kick back in, and resulting in a normal heart rhythm that will provide perfusion and keep that patient alive and result in ROSC or return of spontaneous circulation. And a good example of that is the rhythm on the right on this slide, which is a sinus rhythm or a normal sinus rhythm. That's what, the vast majority of people walk around with on the planet right now. All of us human beings, the vast majority of us, not everybody, but the vast majority all have a normal sinus rhythm. Okay. So that's how a defibrillator saves a life. Here, this slide is a good example of how to utilize and place those pediatric AED pads. So notice the left-hand side of the slide, you have that traditional placement for the child. That top picture on the upper left is a child, so it's upper right, lower left, right? And then we have the alternative position in a child, which is anterior, posterior, or on the front and then on the back. And then the right half of the slide shows the same placements, both the traditional and the alternative for infants. The key point is, if you're asking yourself, when do I use which one? So normally, when possible, use the traditional method, the upper right, lower left placement. However, if the pads are touching each other, that's no bueno, that's no good. Then you need to resort to the backup plan, which is the alternative position, which is anterior, posterior. Okay. Now I'm going to show you a short video which goes over and reviews and gives you a good example of good quality or best practice, a best practice example of infant CPR.
Welcome to today's video on healthcare provider BLS for the infant. Let's take a look at what those steps look like, shall we? Hey, Doc, Jeff. Who throws a baby? Step 1, establish unresponsiveness. 2, assess for breathing. If this infant is not breathing, call a code immediately, get some help coming. You look cutie. And you're unresponsive. And you're not breathing. Nurse, call a code, I need some help in here. Next, check for a pulse. Check for no more than 10 seconds. If this infant does not have a pulse, immediately begin chest compressions. Check for a pulse. I got no pulse. Great. That's fantastic. My kingdom for 2 nurses right now. There goes my kingdom. I need you guys to take over CPR on this little one. You ready?
Yes.
Now in 2 rescuer CPR for the infant, the way we perform compressions is with a circumferential grip. Our thumb's on the sternum between the nipple line, and we're going to compress about 1/3 the distance anterior posterior of this kid's chest. So almost halfway through this kid's chest you're pushing. Again at a rate over 100 and a compression to ventilation ratio of 15:2. Okay, remember, we're going to do our compressions 15:2, 15 compressions, 2 breaths of air. Watch for that chest rise. Good. Circumferential grip. Remember, you're going to compress about 1/3 the distance through that kid's chest, okay? This is an infant, not a child. Now, if all you have is an adult BVM, you can still ventilate an infant. Take the mask and invert the mask. Turn it upside down. So on the adult, where the nose would normally be, we're going to spin that over and we're going to put the nose section down by the infant's chin. The face mask will then come up and cover the rest of the face. You're going to have to cut down on the amount of volume you give this infant, and we're just looking for a little chest rise. That's all. But again, if all you have is an adult mask, you can still ventilate an infant by inverting the mask.
Okay, so some take-home points for that. All right, that was 2-person infant CPR. That was the overview for it. Some takeaway messages are: notice where they checked that infant for a pulse when they were doing their life check. All right, checking both respirations and checking the pulse for up to 10 seconds. They check the brachial pulse, all right, which is on the medial aspect or the inside of the upper arm. So if this is our patient, all right, notice that it's on the inside of the upper arm, all right? That's the brachial pulse in infants. That's the pulse we check before we start CPR in our infant patients. Second point to remember is that, remember, the chest compressions are 1/3 the diameter, the anterior posterior diameter of the thorax, or about 1.5 inches, about 1.5 inches for proper chest compressions. And then finally, third, remember that the chest has to go up and down. You need to see that chest rise and fall when you're giving artificial ventilations, when you're using your pocket mask, your ambu bag, your BVM, or in a last-ditch emergency doing mouth-to-mouth resuscitation. We obviously want to try to avoid that whenever possible due to infectious disease concerns, all right? And, so use your proper PPE, use your personal protective equipment, your gloves, face shields, ambu bags, your mask, iPro, etc. But remember, you need to see that chest rise and fall to make sure that you're effectively ventilating that patient. If that chest isn't going up and down, you're not doing anything useful. You got to figure out where the problem is and fix it. All right, our next video here is going to show good quality or best practice technique for child CPR. All right, so this is good quality 2-person child CPR.
Today we're going to review BLS for the healthcare provider for the pediatric patient, for the child. Let's take a look at those skill steps now. First, establish unresponsiveness. Next, look for breathing for about 5 seconds. If this child is not breathing, immediately call a code, get some help coming. Now, in healthcare provider 2 rescuer BLS for the child, our compression to ventilation ratio is 15:2. You're going to provide 15 compressions, then provide 2 ventilations of air. We're still going to attach this child to an AED to see maybe if they are in a shockable rhythm. Let's take a look and see what those skills look like, shall we? Hey kid, you okay? This kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. And go right to 15 to 2.
Place electrodes.
The AED's here.
Place electrodes.
Hands on him.
Place electrodes. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
This kid's got no pulse.
Two-person child CPR, two-person child CPR, or pediatric CPR. Now, couple takeaway messages with that. Notice as soon as the AED became available, they applied the pads and they started using the AED. Okay, that's critical. As soon as the AED shows up, you need to use it. All right, so that was the first takeaway message. Second takeaway message was notice as they were applying the pads, the other rescuer did not stop chest compression. So they worked around him. All right, that's also critically important. You want to minimize your interruptions in CPR to 10 seconds or less. And remember, 80% of the time, you should be doing chest compressions while you're on scene of a code. All right, 80%. And then the final was, notice there actually was a typo or an error in that last part of this video. So they mentioned there the compression ventilation ratio for two-person child CPR was 30:2. That's incorrect. Remember, it's 15:2 for two-person CPR. The compression ventilation ratio is 15:2. There was one little error there. Okay? All right, moving on. So what is pit crew style CPR and why do we care about it? We care about it because pit crew style CPR as a treatment technique or as a way EMS operates on the scene of cardiac arrest maximizes the chances of you as an EMT regaining ROSC and achieving that holy grail of saving your patient, getting that return of spontaneous circulation. Woo! All right. So if you want to win, you want to cheat death, go ahead and start making sure you guys practice pit crew style CPR. And if your rescue squad, ambulance corps, fire department, whoever you guys volunteer or work with as a career EMT, all right, make sure you guys implement pit crew style CPR because it does make a difference. The research is out there. It's been proven and it's pretty rock solid. So let me give you a good example of why we think it actually works. So they did a study from 2011 to 2013 in Austin, Travis County, Texas. All right. And what they found was when they compared survival rates of pediatric cardiac arrest patients who suffered out of hospital cardiac arrest, the survival rates went from roughly 6.4 to 6.4 or 8.6%, somewhere in that range, to almost or about 17%. So they went from about 6.4% all the way up to 17%. All right, they more than doubled the survival rate once they implemented pit crew style CPR. That's why it matters. That's why it makes a difference. Now, what is pit crew style CPR? Pit crew style CPR is a method or a series of procedures that we can utilize while we perform CPR in the field, all right, as first responders. And it has three main components or three main characteristics. Okay. The first is that we have a designated leader. Somebody's in charge. All right. Whether it's the paramedic, the EMS lieutenant, the duty officer, the battalion chief, or even just the senior EMT. All right. Somebody's got to be in charge. And ideally, they're not doing CPR. All right. They are directing, they're coordinating, they're giving orders, they're making sure everything's being done, and they're providing that quality control to make sure everybody's operating effectively and efficiently. That's what the leaders should be doing. Okay. The next big point or component of pit crew style CPR, after the fact that we have a leader, is that everybody has a role. Everybody has a specific duty, and everybody knows what that role is and what they're supposed to do and how it works or interacts with everybody else on the team. So you need to practice. You need to train. This isn't something you can just do cold. All right. You need to practice at this. Just like that pit crew in the NASCAR race there on the slide. Do you think they just show up for work and go, okay, let's try this out? No, they spend hours and hours and hours practicing and training. And that's why they're that good. So if you want to be that good doing pit crew style CPR, you need to practice and train because everybody needs to know their role. And if you look at the roles there, there's ideally, if you have enough personnel, and we all realize this may not be the case, you may not have enough personnel, but ideally, you would have 6 first responders working as a pit crew for that cardiac arrest patient. So one is the leader. All right, look on the slide there, and notice they're in a position where they can view everything. They can see what's going on. Then we have ideally 2 personnel at the head, managing the airway and providing effective ventilations. So we have 2 people doing that, especially at the BLS level. So you need 1 person to hold the mask in place and maintain that airway with the manual head tilt, chin lift, or the jaw thrust, depending on whether it's a medical or trauma patient. So if it's a medical patient, you do a head tilt chin lift. If it's a trauma patient, you do a jaw thrust. They're going to maintain that airway and hold that mask seal to make sure there's no air leaks or any other problems. Then you have the other person, the third person, who's actually ventilating that patient. All right. So you need 2 people to do effective airway management, maintain the airway, drop a BLS airway, like an oropharyngeal airway or a nasopharyngeal airway, and then maintain the mask seal and provide the ventilations. So we have 2 people doing that ideally. Then you also have 2 people doing CPR, all right, because they need to switch out every 2 minutes. They're going to get tired, and you may have to rotate personnel. But ideally, you would have at least 2 people doing chest compressions so you actually give those people a break and let them regain their strength and their endurance. Then finally, we also have somebody who's responsible for the AED. All right. They're the one monitoring stuff. They're the one, making sure the AED is utilized safely and effectively. And they're the one hitting the shock button. All right. And making sure everything's clear and everybody's safe before they hit the shock button. All right. So notice all the different roles. Notice everybody's job. That's really important with pit crew style CPR. All right. So the third and final point, which is equally important, is you need to have closed loop communication when you're doing pit crew style CPR. What do I mean by closed loop communication? I mean that if you are the leader, you're the first responder in charge, when you give an order, you need to make sure that it's understood and it's acted on, and that the person you're communicating with understands your order and is able to effectively implement that order. And then they respond back to you by confirming that they understand and that they're actually doing it. All right. That is closed loop communication. So when you communicate with somebody, remember that message, that communication needs to be understood by whoever you're talking to, and they need to be able to act on it, understand how to act on it, and how to carry out that order effectively and efficiently. All right. And then they need to, that person who you're communicating with needs to, excuse me, communicate that back to the leader that the message was understood, it was received, and it's being acted on. So, for instance, if you as the leader see a problem with the ventilations, you notice that, hey, that chest wasn't rising and falling, you could make the point where you talk to the two people that are managing that airway and say, hey, I need you to double check things and make sure you're getting air in when you squeeze that ambu bag or you squeeze that BVM. And so then the two people who are performing that skill at the airway, at the head of the patient, need to understand that and say, Roger that, sir. Okay. And we're going to double check things. And then when they do ventilate, they need to double check and say, yes, we're getting air in. The chest is going up and down now. Or no, we do have a problem. You are correct. The air is not going in. And now we're going to try to fix it. All right. That communicated back to the leader closes that loop and ensures that you have closed loop communication, which results in the most effective CPR possible. All right. So again, the three important components of pit crew style CPR is that you have a leader, everybody has a role and understands their role, and they're trained in that role. And then 3, everybody utilizes closed loop communication. All right. So those are the essentials, people. That is what BLS CPR is. Okay. That's the essentials of it. That's the meat and potatoes. That's the essential components of BLS pediatric CPR. It's what CPR is. It's why it's important, why we use it. All right. How to do it effectively, and all the associated stuff with that. Defibrillation, pit crew style CPR, how we prevent CPR. How we prevent cardiac arrest in our pediatric patients. All right. You know, the pediatric chain of survival. All of that is included in the pediatric BLS cardiac arrest protocols. Now, we're going to go ahead and do some review questions to make sure you guys were not falling asleep, not drooling on your keyboards, not in the bathroom for the last hour plus time, and that you guys actually listened and you learned something. So here we go. Review question number 1. True or false? You can use adult AED pads on a pediatric patient if you don't have pediatric AED pads. All right. So can you use adult AED pads on a pediatric, i.e. adult infant or child patient if you don't have the pediatric pads? What do you guys think? Think about that. Roll that around in your head. All right. So can you use adult pads on a pediatric patient? That's our first question. All right. Review question number 2. What is the proper depth and rate of compression for 2-person infant CPR? So what is the proper rate and depth of compressions, chest compressions, for 2-person infant CPR? All right, take a look at your 5 options there, A, B, C, D, and E, and try to figure out which one it is. I'll give you a couple seconds there and think about it. So if you're doing chest compressions on an infant, how fast and how deep do you do those compressions for 2-person infant CPR? All right, and then our review question number 3. What is the maximum amount of time you want to stop CPR during resuscitation efforts. So what's the maximum amount of time you want to stop CPR or interrupt CPR while you're doing BLS and ALS resuscitative measures on your pediatric patient who's in cardiac arrest? Is it 5 seconds, 10 seconds, 20 seconds, or 60 seconds, a minute? Which one of those? 5, 10, 20, or 60 seconds? Think about it. All right. And here's our answers. Number 1, true. The answer is true. Yes, you can use adult AED pads on pediatric patients as an alternative. All right. It's better, remember, it's better to shock with the adult pads than not to defibrillate the patient at all. All right. It's still going to give them a better chance at survival, even though it's not ideal. Now, remember, vice versa or the reverse is not true. You cannot use pediatric pads on an adult patient. All right. The answer to number 2 is C, Charlie. All right. You're going to compress. If you're doing 2-person infant CPR, you're going to compress that chest about 1.5 inches or 1/3 of the anterior posterior diameter of the thorax of that infant. And you're going to compress that chest or do chest compressions at a rate of 100 to 120 compressions per minute. So 2-person infant CPR, you're doing CPR, you're doing the chest compressions at 1.5 inches for the depth and 100 to 120 compressions a minute. And then our third and final review question answer, all right, is B, bravo, 10 seconds. You do not want to interrupt your CPR or your chest compressions for more than 10 seconds. And you also want to minimize the number of times you stop CPR. And remember, our third and final point to remember with chest compressions is not only do you want to not interrupt your CPR or your chest compressions for more than 10 seconds, and you want to minimize the number of times you interrupt, you also want to be doing chest compressions about 80% of the time you're on scene. All right, so you want that CCF or that chest compression fraction to be at about 80%. That is critical. That's going to give your patient the best chance at survival and for you as an EMT, first responder, to be able to get ROSC or return of spontaneous circulation. Holy grail, people. Woo! All right. If you have questions, please get a hold of either your instructor and or customer support. All right. So if you have questions, technical questions about anything in this lesson plan, go ahead and get a hold of your instructor and or customer support, who you can reach via email. Okay. These are the references, and I want to thank everybody. You all have survived pediatric BLS CPR or pediatric BLS cardiac arrest protocols. I want to thank you one and all for showing up. Hopefully you found it mildly amusing, mildly entertaining, and more than mildly educational. Hopefully you learned something. It'll help you guys out when you graduate and become EMTs and you're working out in the field as an EMT. I wish you all the best. Good luck and goodbye.